on behalf of Macleods Pharmaceuticals, we welcome you to this edition of Medlive. We have with us Dr. Uday Jadhav. Dr. Uday Jadhav is a renowned cardiologist from Mumbai and has got exhaustive experience in the field of cardiology for the past 35 years. He has been associated with multiple congresses as well as landmark clinical trials. We welcome Dr. Uday Jadhav. So, sir, welcome. My first question to you is that dealing with heart failure in the year 2022, what is there in the cardiologist armamentarium?
Thank you, Dr. Amit. Yes, that's a great question. Over a period of years, all that we had in the heart failure therapy were our traditional drugs. So we had loop diuretics, we had beta blockers, we had ACE inhibitors, and in patients who could not tolerate that, ARBs, which of course did not have the same endpoint reduction as ACE inhibitors. But effectively what happened is that the MACE as well as the cardiovascular mortality did not reduce significantly. There was some improvement in the heart failure hospitalization, but we have to go beyond that. The last 2 years, after the advent of new therapies, which we will discuss, what primarily has happened, let's say if we include the main pillar or edifice of therapy, SGLT2 inhibitors, then we have a very robust reduction of cardiovascular mortality, first heart failure hospitalizations, and multiple other pleiotropic benefits that we did not encounter before. For example, sparing the kidneys, improving the eGFR, and reducing the decline of the eGFR that is traditionally seen in patients with heart failure.
Next one. Dr. Jadhav, what are your views on recent and emerging clinical evidence of SGLT2 inhibitors in heart failure?
So this year has been great because we saw SGLT2 inhibitors becoming the mainstay, in my opinion, the mainstay of heart failure therapy. We had Emperor Reduce and now DAPA-HF, two pivotal studies that have concluded in the same fashion. So if you look at DAPA-HF, there has been close to 27% reduction in the CV events and or the heart failure hospitalizations, and a very robust 30% reduction in the heart failure hospitalization. So first heart failure hospitalization went down significantly. Importantly, the CV deaths also went down by about close to 17%, and the all-cause mortality too reduced. That means the safety, besides the efficacy of SGLT2 inhibitors in heart failure, got established. There are two other important aspects, or three I may want to quote. Number one is that these benefits were seen both in diabetics and non-diabetics at a fixed dose of dapagliflozin of 10 milligrams. Second is the preservation of the renal function as an add-on effect. The reduction in the slope of decline of the eGFR, meaning thereby that the kidney function would be very well preserved, is a very salutary effect. And third, the improvement in the quality of life. After the advantage we got with sacubitril valsartan in improvement of quality of life, now after DAPA-HF publication and our own clinical experience, the quality of life improves so substantially with dapagliflozin. Patients who are sick, could barely do their day-to-day activity, are able to now do all their household chores, move around, do their normal walks. I think this is a tremendous advantage.
Sir, the clinical evidence with DAPA-HF trial and the recent 2021 ESC guidelines for heart failure place SGLT2 inhibitors like dapagliflozin with mortality benefits, and they are recommended as class 1A evidence in heart failure with reduced ejection fraction. How does these findings translate into the clinical practice of a cardiologist?
Yes, thank you, Dr. Amit. That you quoted the guideline makes it very straightforward now. Class 1A indication based on the way we classify a given medicine makes it absolutely mandatory now that dapagliflozin be used in all patients who come with heart failure, irrespective of their diabetic status. Now, have we done that in practice? Is our experience tallying or being carried forward from the clinical experience of DAPA-HF and Emperor reduced, and now with the European Society guideline, yes. So now we have started utilizing this class of drugs, SGLT2 inhibitors and dapagliflozin in all patients who are in HFrEF, heart failures with reduced ejection fraction. We also now tend to include this class of drugs for HFpEF. The only query which was there before, how early you can start it. So now we have DICTATE-HF with dapagliflozin, an ongoing trial. We already have the empagliflozin data released at the AHA for early use. In my opinion, if you have to start something in a heart failure patient who is stable, the medicine which you can start absolutely quickly and earliest in heart failure is the class of SGLT2 inhibitors. So all thumbs up for dapagliflozin to be initiated early. I do that, generally speaking, 3 to 4 days after the patient is hospitalized, stable, off diuretics, off inotropes, BNP levels are stable, blood pressure is stable, and then continue this therapy throughout his hospital stay and post-hospitalization to achieve the maximum benefit. So yes, the guidelines have translated in clinical practice and our experience has got enhanced because of it.
So, sir, what are your final takeaway messages to our audience today?
Well, in conclusion, dapagliflozin and the class of SGLT2 inhibitors should be used in every patient of heart failure. It should be the first drug to be initiated in the heart failure therapy because it's easiest to initiate. Please do not worry about hypoglycemia. It does not cause hypoglycemia in non-diabetics. Please do use it in diabetics and non-diabetics. Very few parameters have to be monitored. And along with the standard of care of sacubitril valsartan, a beta blocker, and a MRA, this class of drugs should be the future for how we are going to reduce morbidity and mortality in India in patients of heart failure. Thank you.
So to sum it all, we can say that SGLT2 inhibitors today offer a new approach to heart failure patients with class 1A recommendation by ESC guidelines. The variety of benefits confirmed by SGLT2 inhibitors make it an attractive option for clinicians in heart failure with diabetes as well as non-diabetes. The effects on quality of life is encouraging as confirmed in clinical practice by Dr. Uday Jadhav, sir.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.